welcome to the court of the Edijester. How are we, good peeps? Oh, I'm very excited today because my monthly teaching is coming around, so I'm getting to see my warrior folk. We're going to be doing some learnings today, so I'm looking forward to seeing everybody. But I'm also very pleased to report that there's some great news, I think, which has come out, which really we need to talk about for a bit. This could be a long one. Get yourself a coffee, right? So what we've got, from what I can tell, he says, is this review of adult gender dysphoria services, which ties in with the work that's been carried out by Hilary Cass, and which includes a couple of letters, one from the 16th of May, one from the 7th of August 2024. So this is hot off the press, and that letter is from John Stewart and Professor James Palmer, directly to Dr. Hilary Cass, in regards to the review of adult gender dysphoria services, which I couldn't be happier about. There needs to be a review, so we can stop it right now. So bear in mind that what we've got is a situation currently where the Cass review came out. There's been changes in what happens to people who are 17 years and under, who are involved in this gender nonsense, and that review has now seen some strong support from Wes Streeting and the Labour government, which has essentially said that puberty blockers are gone. I don't think there's going to be many doctors left that are going to be willing to refer anybody for any of this kind of nonsense for very long, because I think the risks are now too great, and we know that the damage is so severe that the whole process is a disaster. So what then happened was James Palmer, who's a big cheese, the old big cheese in the NHS, he's the Stilton of the NHS cheese board, right, wrote a letter saying, yeah, we're going to have to look at the adult stuff too. That was some while back. Here's the result of that. So I'm going to do a cold reading. I haven't looked at it much, although I have to say the little bit I have looked at is rather like putting your feet in front of a fire after you've been walking up a cold mountain. So I think this is good news. I will await, of course, your response in the comments as per usual. So here we go. Review of adult gender dysphoria services. One of the recommendations of the Cass review was a review of the adult service specification, because Dr. Cass also highlighted broader issues that were reported to her during her review. Now, so we then got the letter, right? So what we're going to do is we're going to take a look at the letter from Dr. Cass. I'm not going to go through it all, but I am going to make sure you've got the links that you need in the doobaries so that you can get your teeth into this as well, because we're all going to need to. Let's get going, right? So, letter from Dr. Cass to John Stewart, the National Director, Specialised Commissioning, NHS England and NHS Improvement, and Professor James Palmer, National Medical Director, Specialised Commissioning. So these are two of the big cheeses involved, and this is from the 16th of May. And Cass says, as set out in my final report, a number of clinicians who currently or have previously worked in adult gender services approached me to express concern about both the clinical practice and model of care. Their experiences cover several GDCs, gender dysphoria clinics, across the country. I have also heard concerns from clinicians in other settings, most specifically general practice, about patients under their care. Cass says it was outside the review's remit to attempt to validate the accounts I received or to determine whether all the issues are still current. In addition, practice and standards may be markedly different between different clinics. However, there were common themes I hope will be explored in the upcoming review of adult gender services that NHS England is planning to undertake. Let's have a look at some of those common themes, people, right? The most common concern was the very limited time for assessment and the expectation that patients would be put on hormones by their second visit. The most common concern, folks. In most instances, the individuals described a first appointment with a non-medical practitioner who was not necessarily clinically trained, and usually a medical practitioner seeing patients at the second visit. The individual described a first appointment with a non-medical practitioner. So who are they? That's what I'd like to know, and I'm sure you may be asking yourself the same sort of question. A non-medical, I think that's the LGBTQ plus LGBTQ lunatic groups. I think that's who that is. A first appointment with a non-medical practitioner. I think it's the loony tune groups, like, GLAD and all that lot, who were ever involved. Stonewall, LGBT Foundation, LGBT Consortium. I think that's who they've been seeing first, and that's what's been driving it. But, you read what you want into it. I'm going to read that. Clinicians who spoke to me felt that in common with the population that is presenting to children and young people's services, the majority of patient presentations were extremely complex, with a mix of trauma, abuse, mental health diagnosis, past forensic history, ASD and ADHD, and therefore this limited assessment was inadequate. These other clinical issues were not addressed or taken into account in decisions to prescribe masculinizing or feminizing hormones. Right. What we've got here is confirmation from Cass that the multi-presentation of clinical problems and of psychological problems of children who have been socially transitioned or who have fallen for this cult are demonstrated right across the board. Into the adult service, we've got the same problem. Mental illness across the board, we've got the same problem. There's mental illness or cognitive problems or abuse and trauma, as you can see there. Surprised? Not really, not surprised, but it's good to see it down and written there, right, right in front of us. It was difficult for clinicians to defend a decision not to prescribe hormones, except in exceptional cases. For example, patients who were sectioned or had multiple personalities. Unbelievable. It was reported that if a patient was self-harming or had significantly unstable mental health, it was not viewed as a contraindication to treatment. It was not viewed as get your head around that, right? So if they were terribly ill with multiple problems, unstable mental health, self-harm, and the people were going, yeah, but that doesn't affect the fact that they want to be trans. Get your head around that. When they say this is a medical scandal, and you and I have been concerned primarily with the children so far, that is not where it's going to end. This is a medical scandal of epic proportions that will include adults. One clinician told me they would be subject to complaints if they delayed putting patients on hormones, and another told me their practice was monitored, and then if they offered a patient too many appointments, this was clamped down on. Because of this approach, further issues sometimes became apparent a few months after hormone treatment had started. There is an ideological framework behind this that is badgering, hounding, emotionally blackmailing, and threatening doctors and clinicians to ensure that the affirmation only approach is taken. It's gobsmacking. I know, it's gobsmacking. Both medical and non-medical practitioners at least two clinics had raised concerns about the marked change in the case mix from predominantly older birth-registered males to predominantly birth-registered females in the early 20s with complex presentations. One person told me that during their time in the service, they saw only a handful of the more traditional cohort for these services, which is older birth-registered males. Consent procedures were inadequate, with limited explanation of risks such as vaginal atrophy, osteoporosis, etc. And several described magical thinking, unrealistic beliefs about what could be achieved through medical transition, which was not corrected or challenged. Sometimes this seemed to be related to watching social media videos. That's Jeffrey Marsh, you numbnuts, and those other Popinolly crap and all the bollocks that's been going on online. And not having the cognitive ability to appreciate the limitations of hormones and surgery. Not having the cognitive ability. In some instances, this led to patients expressing dissatisfaction with their medical transition. What a surprise. And there are no national treatment guidelines regarding use of hormones and access to endocrine advice. It was variable between clinics. It's just insane. Psychiatrists who provided second opinions for use for surgery for one of the clients writes boilerplate letters which do not reliably reflect the individual patient. It's a factory. It's the template, get on with it. Administrative processes were described as chaotic. Adverse outcomes. Clinicians informed me that suicides of patients on treatment were not formally discussed in morbidity and mortality meetings, with no clear strategy for determining whether there were lessons to be learned for future cases. I heard that detransitioners tended to move between clinics, often not returning to their clinic of origin, and there was no system for informing the originating clinic about them. In one clinic, regret was treated as a new episode of dysphoria. Oh my God. There was a perception from some that the approach was ideologically driven and polarized. It was difficult to question the approach or discuss concerns. Clinicians described a philosophy that it was up to patients to make their own mistakes. Up to patients to make their own mistakes. Oh my God. People presenting with really complex problems, many of them same-sex attracted, it was up to them to make their own mistakes. Ooh, that's quite a hard read. Anyway, By the way, just don't get bogged down. That's from Cass, right? So that was the letter from Dr. Cass to John Stewart. Then, right, we have an update on work to transform the gender identity services. To Dr. Hilary Cass. Here we are. Dear Dr. Cass, we wanted to update you on the progress NHS England is making to transform and expand the provision of care in children and young people's gender services, in line with your recommendation and advice, as well as work underway to review the gender adult services. We know that children, young people and their families are worried and distressed about the time it can take to access treatment and support. While the transformation of our services will take time, we are today setting out the next steps of NHS England plan to implement the recommendations set out in your final review. This will include, now, here's the bit we've got to be careful of. Expanding service delivery with a specialist service in each of the 7 regions. I was worried about this prior to getting this, and I was told I needn't be, that it would be okay, and they were right. I was wrong, right? So I was worried about this. When you get to look at the service delivery, which you could do yourselves, go and have a look, you'll find that they've added in such safeguards, that it means that those services are certainly not going to be providing what was providing before, and that any sort of medical intervention is likely to be way down the list. So I feel heartened by some of this now. They're bolstering workforce development and training, finalising the service specification, as well as a revised clinical policy for gender-affirming hormones. A revised clinical policy. Well, the clinical policy was give it to them. So the revised policy is obviously going to be don't give it to them, or at least don't give it to them as quickly as you would, or as easily as we might have. They're supporting the providers to establish a national provider collaborative, which in time will take the lead on the approach and delivery of clinical management and future research activities. And they're completing a study that links the data from the services provided by the former GIDS, that's the children's service, to an adult data set. They're bringing the two together. What's happening here is they are saying, fine, we've got a child service, we've got an adult service, but what we're going to do is we're going to look at it as one thing, because if there's an ideological framework pushing it, it's being pushed from when they're 3 years old to when they're 90. That's how they're going to treat it. This is, to me, the clearest indicator that they know what they've got on their hands is an ideological framework and a medical scandal. I think this is good news, folks, but you're going to have to let me know, because you'll do more in-depth work on this than me. So, the National Research Oversight Board continued to oversee the process for establishing a clinical study into the potential benefits and harms of puberty-suppressing hormones for children and young people with gender incongruence in partnership with the National Institute for Health and Social Care. I don't think it will happen. The National Research Oversight Board continued to oversee the process for establishing a clinical study. Right, this has been another worry, hasn't it? How can you have a clinical study? Because you need people that did have it, people that didn't have it. It was all sorts of problems would have been involved. I think them saying the National Research Oversight Board continue to oversee the process means that the Oversight Board will never let one happen. That's my thinking. But again, over to you. You tell me what you think. And so on, right? Furthermore, let's look at the referral pathway. NHS England is also publishing the new referral pathway specifications. So let's have a very quick look at that. The referral pathway specialist service for children and young people with gender incongruence, which comes as a couple of PDFs there, right? A couple of PDFs, and there's a summary. And what's particularly interesting is in this actual summary, which you can see here, and the proposals that come with it, none of it refers to anything to do with trans. It's all about gender incongruence. That's taking centre stage now, gender incongruence, which is a whole different ballgame to the usual language of gender dysphoria, gender identity, trans joy, etc. That doesn't mean to say that in some of this stuff that I've already read, that you haven't got the nutters going, well, this stigmatizes trans people because there's nothing wrong with them mentally. Well, I'm afraid that it looks like the evidence is that there is something wrong with most of them mentally. And I'm not surprised by that, having met many. I'm not including in that the fetishistic men. The fetishistic men and the paraphilic men and are a different ballgame. This is nothing to do with that, with the fetishists and the paraphiliacs. So there's the update there. Okay, so there's the update there. Now, we then have the consultation report. Now, let me take you to the top of this just quickly, because I don't want to labour the point, because you can do your own work. What they've done is they've talked about how they've consulted, who they've consulted, the proposals, how was feedback considered. So they're telling you how they've done what they've done. but there's some important stuff here that's just worth mentioning. There will not be a minimum age threshold. So in other words, in line with recommendation 4 of the Cash Report, April 2024, that says that when families or carers are making decisions about social transition of prepubertal children, NHS services should ensure they can be seen as early as possible by a clinical professional with relevant experience. What they're saying there is that children can be referred as young as 2, 1, 0, for God's sake. They can be referred as young as in their first year. This is very important, I feel. And it will give a reaction. Generally, our reaction would be, what the are they doing? Well, I'll tell you what they're doing. They're now treating it as a safeguarding concern. That's how I see this, right? They'd be seen as early as possible by a clinical professional with relevant experience. The primary objective of the service for children under the age of 7 will be to provide support and guidance to the parents' carers rather than initiate clinical interactions with children. The appropriateness of a referral of a child under 7 years would first be agreed by the referrer and provider of children and young people's gender services through the pre-referral consultation service once this is operational. This will stop the trans housing by proxy of these insane parents. That's what I think that's there for. And it should be, well, I imagine I would like to see when this finally comes to fruition, that there will be a referral process for worried friends, family, worried social workers. And social workers are going to need great support from the public on this. We really are going to have to give social workers great support. This is my initial cold reading. I'm going to wait to see what you've got to come up with. But when you go down, what's really interesting is Appendix A, which is the response to consultation and submissions. So there's the particular question, then the response from people who agreed, and then you get the response from people who disagreed, and then you get the response from those who were like, well, maybe not. Okay? So, for example, the response to the question about referrals from the people who disagreed with the proposal said that there was a concern that there are transphobic opinions held within the NHS and that this change could be considered gatekeeping or deliberate obstruction to treatment. Oh, I do hope so. And the NHS have replied no evidence was offered during consultation that would support the claim that secondary care clinicians would seek to deliberately obstruct access to a clinical pathway. The objectives of the proposal are to increase the quality of the referral information that accompanies the child or young person into the service, thereby reducing the risk of unnecessary delay at the assessment stage, and to ensure that the health needs of children and young people are identified and addressed at the point of referral while they remain on the waiting list for gender services. The other big one that's in here is that what was going to happen was, so the child gets to 17 years and whatever it is, they automatically then go onto the adult list. That's no longer happening. What will happen is they will drop off and they'll need to go to their GP to get a new referral. I can see what's coming now, and I hope that you can too. We're beginning to see the move towards the eradication of the concept of gender identity or gender identity at all. What I will hope to see that comes out of this is an absolute plummeting in the number of adults that will get permission to do this, and I think we will see that drop off over the next few years. In essence, what I think we will need to do then is keep an eye on to watch them like hawks by all means. Watch them like hawks by all means. We'll need to set a standard within private practice. So in other words, then the government of the day, whoever it may be, is going to have to deal with how do we prevent people travelling abroad to have these mutilation surgeries done, and how do we prevent adults from getting it done in this country, which is a whole different ballgame. But I think that this is a very good start. I feel heartened by this morning, and I hope you do too. So it's over to you. Have a look. People are going to pull this apart from now until Christmas. But I think we can take some hope from this. And that's the message I'll be taking to me warriors later on as we meet and discuss as we do things of interest. Right? That's it. Jester out. Let me know what you think. Come and join the Warrior Teachers. September start. I'll see you later. Bye-bye.